welcome to my channel. So today we are going to go through IMED theory episode 1. So we just go through 10 questions, 10 IMED theory questions that we have prepared. Okay, so question 1 says a 30-year-old male patient reports a 2-month long history of epigastric pain whenever he has a meal. He has consequently become very fearful of eating and has reported his clothes generally becoming loose-fitting. He has a positive history of smoking for 4 years and taking beer on weekends. Then what is your diagnosis? List 3 differential diagnoses. List the 3 key diagnostic tests that will confirm your diagnosis in A. Then list 2 supportive investigations and explain their relevancy to this case. Then list 5 complications of this condition. Then list 5 risk factors for the development of this condition. Then G, outline management principles for this said condition. Okay, so this is someone who has come in and has reported a 2-month long history of gastric pain whenever he has a meal. He has also consequently become very fearful of eating and has noticed his clothes becoming generally loose-fitting. He has a positive history of smoking for 4 years and taking beer on weekends. Okay. Then our diagnosis will be PUD, then specifically in brackets, or specifically you can just put gastric ulcers. Okay, so you can just put gastric ulcers. Then for differential diagnosis, we can have gastritis, stomach ulcer, gastroesophageal reflux disease, inflammatory bowel disease, diverticulitis, diverticulosis, and pancreatitis. These will be our differentials. Then for the key investigations, we can do a barium swallow, we can do a barium meal. So for the barium swallow, so specifically let's just do a barium meal here. So once you swallow, let's just do a barium meal. So barium meal X-ray. Okay. Then abdominal ultrasound if you want to rule out other things, because if you want to rule out other things, not a confirmatory diagnosis, then urea breath testing is one of the confirmatory diagnoses, and 2 antigen tests for the H. pylori. So here we have barium X-ray, barium meal X-ray, it's a confirmatory. Urea breath test, confirmatory. 2 antigen, confirmatory as well. Then endoscopic procedure, you can do esophagogastroduodenoscopy as the confirmatory diagnosis. So this is a definitive diagnostic test. Okay, then the supportive investigation, this is where the abdominal ultrasound is going to come in. So the abdominal ultrasound is going to come in on the supportive. Then chest X-ray, of course, is also going to come in, especially if there are signs of perforations. You can do a chest X-ray. We check for the under the right hemidiaphragm. Then if they tell you it's a perforated PUD already, then the chest X-ray should be one of the diagnostic investigations. So that's how we move around the investigations. Then for full blood count, just rule out anemia or any infection by the increased white cell count. You can do our LFTs and the blood culture. Okay, then 5 complications of this condition. So for 5 complications, you can have peritonitis, hemorrhage, perforation, hematemesis, narrowing and obstruction. You can lead to a pyloric. Then you can have gastric outlet obstruction and a gastric carcinoma. These are some of the complications that might set in. Then for list 5 risk factors for development of this condition, you can have lifestyle factors such as smoking, alcohol, acidic drinks, and medications. Then H. pylori infection can have Zollinger-Ellison syndrome. So we can have both of those two. Okay, so these are some of the risk factors for development of this condition. Then for outlining the principles of management principles of this condition, of course, our resuscitation has been done. We do our resuscitation, then lifestyle changes. So we tell the patient to stop smoking, stop ingesting NSAIDs and other risk factors. Okay, then another risk factor here you can just put is stress as well. Okay, then after that, then we have to give omeprazole, clarithromycin, amoxicillin, or metronidazole. Okay, so in a case where there is no clarithromycin, then that's only when people find them prescribing both amoxicillin and metronidazole. But in the actual sense, it's supposed to be clarithromycin with either amoxicillin or metronidazole. But if clarithromycin is not available, then you opt for. Then that's only when you opt for both amoxicillin and metronidazole. Okay, so typically that's the end of question 1. Then you can go to question 2. So classify with examples the causes of anemia. So these are at least more good in terms of people retaining data. So of course we have blood loss, where we have acute GI bleeding, we have menorrhagia, open trauma. Okay, and we can have a decreased or inadequate production of normal blood cells. So what will cause a decreased or inadequate production of normal blood cells? You can have nutritional deficiencies such as iron deficiency, vitamin B12 deficiency, and the folate deficiencies are nutritional deficiency under decreased or inadequate production. So iron deficiency, vitamin B12 deficiency, and folate deficiency. Okay, then we have bone marrow suppression under the same decreased production, where infections causing the bone marrow suppression as HIV, TB, malaria, schistosomiasis, hookworm infestation, and hepatitis. You can also have drugs such as isoniazid, where we have drugs such as isoniazid, chloramphenicol, alcohol, zidovudine, and fluoxetine. These are some of the drugs under the bone marrow suppression part. Then for chronic disease, you can have renal and liver disease, you can have rheumatic disease as well. Okay. Then hemoglobinopathies, we can have thalassemia and myelodysplastic syndrome under the bone marrow suppression under the hemoglobinopathies. We are done with bone marrow suppression on chronic disease. Then hemoglobinopathies, these are just other factors that can cause decreased or inadequate production of normal red blood cells. Okay, then the last classification is excessive destruction of blood cells, where there is hemolysis. So which factors can cause this? So we can have hereditary hemolytic anemia, where we have sickle cell disease, thalassemia. We can have glucose 6-phosphate pyruvate, glucose 6-phosphate deficiency. You can have pyruvate kinase deficiency. These are some of the enzymopathies that can cause excessive destruction of blood cells. You can have membranopathies such as hereditary spherocytosis and erythrocytosis, which can cause hereditary hemolytic anemia. Okay, then we can also have acquired. So we are now away from the hereditary, we are now on acquired causes of excessive destruction of blood cells. So we can have microangiopathic hemolytic anemia causes such as TTP, HUS, which is hemolytic uremic syndrome, disseminated intravascular coagulopathy, eclampsia, HELP syndrome. This can cause excessive destruction of blood cells. You can have autoimmune hemolytic anemia. You can have paroxysmal nocturnal hemoglobinuria. underacquired. Then underacquired again we can have hypersplenism. Okay, then we can have infections such as malaria. We can also have infections such as malaria. And then that's the end of the classification for the causes of anemia. So we said A, we said blood loss, that was A. Then B, we said decreased or inadequate production of normal blood cells. Then C, we said excessive destruction of blood cells, that is hemolysis. Then we are giving examples under each. That was how we classified them. Okay. And then question 3, classify with examples the causes of jaundice, 5 marks. Okay, so we can classify them as pre-hepatic, hepatic, intrahepatic, and post-hepatic. So pre-hepatic, we can have hemolysis causes such as malaria, sickle cell disease, thalassemia, glucose 6-phosphate dehydrogenase. Okay, then you can have intrahepatic causes such as viral hepatitis, drugs, alcohol, alcoholic hepatitis, cirrhosis, pregnancy, recurrent idiopathic cholestasis. These are some of the intrahepatic causes. Then for extrahepatic or posthepatic, you can have common duct stones, bile duct carcinoma, head of pancreas carcinoma, ampulla carcinoma, biliary stricture. You can have sclerosing cholangitis. You can also have a pancreatic pseudocyst. Okay, so we classify them as pre-hepatic, intrahepatic, and post-hepatic. Okay, so these are some of the this is how you classify the causes of jaundice. Okay, then the reason why we classify them this because this is we are more over talking about the pre-hepatic, intrahepatic, and post-hepatic. But it's for this when we are talking about surgery, it's another story. So we have to classify the post-hepatic. We use the post-hepatic where the obstructive jaundice, and that's where the intramural, postmural, and whatever comes about. Okay, just from the post-hepatic alone. Okay, I think we can now move on to the next question, which is question 4, which is saying acute and chronic complications of sickle cell disease. So what are the acute and chronic complications of sickle cell disease? Okay, so under acute, we can have acute chest syndrome, we can have priapism, we can have acute splenic sequestration, vaso-occlusive crisis pain, aplastic crisis, and acute abdomen. Okay, then under the chronic complications, we can have leg ulcers, cardiomegaly, arrhythmias, and iron overload, cardiomyopathy, chronic hepatomegaly, liver dysfunction, retinopathy, renal failure. We have chronic tuberointerstitial nephritis, we have jaundice, anemia, delayed growth and sexual maturity, avascular necrosis of hips or shoulders. You can have chronic pain, you can have pulmonary hypertension, and cerebrovascular disease or stroke. You can also even a TIA can be present. Okay, these are some of the complications of sickle cell disease, acute and as well as chronic. Okay, then for question 5, saying outline with classification the known causes of renal failure. Outline with classification the known causes of renal failure. So we have renal causes such as volume depletion due to hemorrhage, renal losses due to renal losses due to diuretics, GI losses such as vomiting and diarrhea. Okay, then you can have impaired cardiac efficiency due to myocardial infarction, heart failure, dysrhythmias, and cardiogenic shock. It might cause a renal failure. You can have vasodilation due to sepsis and anaphylaxis. Okay. Then you can have intrarenal causes, such as prolonged renal ischemia due to hemoglobinuria, which can be as a result of transfusion reaction or hemolytic anemia. You can have myoglobinuria, which can come in as a result of trauma, crash injury, or burns. You can also have a pigment nephropathy, which is associated with a breakdown of blood cells containing pigment that in turn occlude kidney structures. Okay, then you can have nephrotic agents, nephrotoxic agents. So supposed to be nephrotoxic agents. Such as aminoglycoside antibiotics, such as gentamicin, tobramycin. You can have radiopaque contrast media, heavy metals such as lead and mercury. You can have solvents and chemicals such as carbon tetrachloride and arsenic. Okay, then you can also have NSAIDs and ACE inhibitors. Okay, so you can have NSAID and ACE inhibitors. Then under the same interrenal can also have infectious processes such as acute pyelonephritis and acute glomerulonephritis. Okay, infectious processes. Okay, then post-renal. So under post-renal causes of renal failure. You can have urinary tract obstruction, including calculi, which are just stones. You can have tumors, you can have BPH, you can have strictures. So these are some of the causes for the post-renal causes of post-renal causes of renal failure. Okay, so I think we can end here, and for question 6 we are going to tackle it in part 2. So just check out part 2 on the channel. So there will be an internal medicine. So question 6 to 10, they will fall under part 2. So just check out the IMED theory questions, part 2, question 6 to 10. Then there will be a lot of revisions. There will be a lot of revisions for IMED theory questions. So just continue checking out the parts. Okay. And then I think we can end here. Thank you for watching. If you haven't subscribed, please subscribe and hit the bell notification. And see you on the next tutorial video, and check out the other parts of the section of these episodes.